Hello and welcome to the Pain Podcast. Today I'm host Tim Beams and I have Bart van Buchem with me.
There you go.
Welcome everybody to the Pub Pain Podcast. And today we're going to talk about the assessment as an intervention. So
How exciting.
yeah, the
Yeah.
safety of a physical exam, or maybe even the role of a physical exam as a treatment in itself as well. So yeah, we've got lots and lots to talk about. So we're going to dive in and just see where it takes us. Now I want to sort of position us. You are literally sitting in your clinic space.
Yeah, I do. Yeah, exactly. That's
And so am I. So I see a lot of my clients online. You see them physically in a room, and there is a difference there, isn't there? Just in terms of what we can do as physical therapists, as people who are interested in someone's body
really,
and
yeah.
how they move and relate. And I think there are strengths and weaknesses in terms of what we can do and how we can
Yeah,
work to both of these as well. So perhaps this is just a little thread that we have running through here.
absolutely. No, I agree. And it makes I feel like I've been working quite a bit of online, seeing patients as well. But it's good to have the options. But I also do appreciate the in the clinic work. But for some people, it's just very hard to get to the clinic. So it limits your regions or your reach in some way. So so I prefer to have the options and appreciate the opportunity to
Yeah.
use for that.
Yeah. And I think that's a good thing to just say. It's amazing, actually, isn't it? How, and I think one thing COVID did quite dramatically for therapies is show that actually there are alternative ways of working. So
Yeah, they proved to be helpful, or in some cases to make a positive difference. I have multiple cases where I can safely say that it made a change in a positive way. It wouldn't have happened without. So, I'm open to both, and you could say like it's hybrid in some way.
yeah,
Yeah.
yeah. So let's jump in and first. So I guess a bit of a caveat is we're not going to be telling someone how to do an assessment and what the best assessment will be or anything like that. But we're going to interrogate what an assessment, a physical assessment, might mean. I want to sort of put it out there that when you perform a physical exam, and certainly how I might teach this, and I'm guessing, or I'd like to hear your thoughts on this as well,
Mm.
is that we're going there with as open mind as possible, aren't we? And but it's very difficult to take away our internal biases as well that we bring to any kind of form of assessment. So I suppose to let just starting off, where do you sit with that sense of openness or neutrality or curiosity or whatever you want to call it then?
Yeah. Well, that requires some reflection. It may change, or it may differ per individual, per patient that I see. Sometimes you do have, so even the patients you've already seen or from a certain area, you might be biased towards having some prediction about, oh, this is probably going to turn out like this. Maybe not even explicitly. It's not like a thinking. I do get, because my caseload is quite people. So most of the patients I see have had quite a bit of history. So my way of dealing with these complexities is basically asking them to send me some information about their medical history beforehand. Otherwise, it would take too much time, in my view, just to basically typing. Um, and it's a time consuming to take. And I think it's quite important to have it right. Right, so to have the history correct and get this historical overview and a timeline. So, and then what I do it is what I, if anyone is doing this, but we're using an AI generator at the moment, which is a safe one, which is selected for these type of medical and anonymous background. So we're just basically dumping all the information in one file, and it extracts in a, let's say, one-pager historical overview, which gives me a good starting point with the patient, and that's where I'm starting. So I'm definitely already primed. So, and obviously I do. So I don't think I'm quite neutral there.
Yeah. Yeah.
But I'm aware of that, and I'm trying to open up because sort of trying to figure out what's not been written down. Otherwise, it's just repeating what's already been written. So trying to figure out the story behind the reports and their feelings and experiences, which is really interesting because that gives you another layer of information, which I think is absolutely necessarily to build a relationship and trust as well.
Mm. Mm. So where do you, so I've got a couple of sort of questions in here then. So I suppose I've been biased in saying it's important to come with a open mind and curious and not too biased, but is that something that you're mindful of when you are meeting someone and going through your physical, your normal therapeutic process?
Yeah, maybe like you, you can beforehand you can sort of disclaim what you are and what you do and what you don't. Obviously, even telling people and asking them to come up with an open mind is already creating some kind of sphere or atmosphere, at least, that requires neutrality or openness and trust. People don't necessarily open up the first session or not tell you exactly what's going on, which is maybe not that's not the goal. But I'm also I'm quite open in sort of asking people what their expectations are, because they do have these expectations. They've been thinking quite a bit. If people don't have any expectations, probably you will figure out what the expectations implicitly would have been beforehand, because they're not always like thoughts and beliefs that people have, but they may have. What I find really interesting after the first session, asking what they think about the first session, how they felt about it. And they say, "Oh, I'm quite relieved." So there must have been some kind of beforehand prediction they have, thinking beforehand, and expectations, and they may have met or not met, and it guides you towards that the session, and now you can see the body language. So that will be my question back to you. How do you find out if the body language is maybe not as similar in an online session as it is in a live session? How do you pick it up?
Yeah. Well, it's a really good point. So what I think I've developed, like obviously over the years, but as I think has developed quite a lot for me, is my ability to listen and notice and yeah. So communication in that respect is that much more important. And there are things that you pick up on the camera, obviously. So if you pick up the signs of some irritation or distress or whatever that might be, that's, just as you would in a room, you can pick that up through a video call as well. So, but then there are bits that you don't see because, you are only taking an element of that picture in.
Yeah.
So you do lose that. Um, but yeah, it's working with an understanding of what you know the strengths of it will be, but also what you lose in working in that way as well. So yeah, yeah, yeah. Um, when you see you made a comment, and I really like this comment because it's something that I heard, and obviously I do see some people in a room together, and it's something that I remember hearing is people saying things like, "I'm so relieved." I think you said, but things like, "I feel so much better having come to see you," and that will be before you've done your treatment, whatever you thought was a treatment. So it suggests that there was a role in the assessment being a treatment in itself, and how could that be then? So if that is the case, if that's what we hear from people, what are we doing in that case?
Yeah. Probably acknowledging that it does have some kind of effect in terms of reassurance in the, let's say, physical assessment you do, or even telling people they're doing all right or they're safe. Um, some people may seek for confirmation, even they knew it was all right. I do have some people who do extremely well on this type of acknowledgement. Although I just have to say that there's a disclaimer there. That there's a group of patients that I see who have this hypochondria. Is it correctly? Which basically means every time you reassure, it's you're repeating the 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 problem basically. It's not gonna help. You're gonna say, "Oh, am I okay? Am I okay?" So some people are more in the fearful mode, if you like, and therefore you have to help them not going into the physical assessment mode again. So I think you just have to be very aware, why do we this assessment? And in many cases, especially in the first episodes, you probably do it because I think it's required in many ways. And it could be very helpful if you learning from and listening to and watching carefully, listening carefully, all part of that. I Yes, it's another. It's also like what you just said is like building trust. Um, and I would never say, well, I didn't do anything. We did a lot, and probably that's something is important to you. So
Yeah.
it meets an expectation that was required to feel better, and it may potentially someone lacking
Hmm.
that
Yeah.
or not receiving a lot of acknowledgement or validation and assessment. And some people will say, "Oh, nobody have done it for years," and therefore I think it's quite powerful. But you have to be aware, right? It should not be a goal on its own.
It's so I'm what I think I'm hearing from you is that there's some sort of meaning making, some sense making going on for both of you. You're not just gathering information to write it down, are you? You're gathering information to understand, but at the same time as you gathering information, that person, that patient, that person who's come to you is also gathering their own information to prove, disprove, reassure, or maybe, maybe not, maybe make them feel a bit less comfortable or safe or whatever it might be. So yeah, it has a powerful effect, doesn't it?
Yeah, yeah. I think it's like you said, it's probably you have to be aware that it might be very powerful and then use it like that, being quite explicit about it. And even after doing it, how do you feel about this right now? So yeah, it's super interesting how you can, if you were aware of it, you would use it more in a way to build trust, but also to gather information about responsive patterns and so on and so on.
Yeah, yeah. There was a time for me, I wonder whether it was the same for you, but certainly when I was a young therapist, uh, I was doing almost every test under the sun. I mean, part of that was that my knowledge wasn't, sufficiently tight that, I
Mm.
wasn't able to streamline the testing as well. But I'm wondering, and certainly I think now, the could I over test? Can you do too much? And what role would that have? Could you under or over test? What role might that
Well,
have?
if you did every test under the sun available, you probably over-tested a bit. Uh,
Well, and it wasn't for research as well. I mean, I certainly remember as a fairly new grad, like having a cheat sheet underneath my notes, and if someone came in with a shoulder problem, I could do this, that, and the other tests. And over time, thankfully, you sort of shape that to a more dynamic reasoning, don't you?
yeah, that I think from the way I've been trained, it's this hypothetical deductive structure. Basically, if you do a proper interview, you probably there might be a case where you don't necessarily have to test anything, right? But you deliberately do because just to show the person that they're all right or not. That's probably, is that over testing? But it's just it has a different, I think for your clinical reasoning is a different approach than it is for connection and validation and trust. That's two different worlds. And as long as it, in my view, as long as you do the clinical reasoning properly, just tick off that box just to make sure you have evidence informed understanding and process that underlies is underpinned by research and understanding of the anatomy, etc. And then it's at the same time or apart from that doing the other stuff that probably gonna build a relationship. I kind of as a newly grad, I would probably go not together. I'll probably start with the clinical reasoning and then basically start ticking off the box of the clinical reasoning and then do whatever is necessary to build that. And you might be over testing there. And there
Mm.
might be a little bit of risk, I guess. What about, yeah, that probably will be some risk. And what the risk would be in over testing is probably if you lose trust, right? People get more worried about it. Um, yeah.
Finer and finer and finer detail. I mean, from a pain point of view, that doesn't, necessarily meet what's needed, I would say.
Mm.
Yeah, we used to have a phrase, and it's been a while since I've even thought about it, but we used to talk about high tech versus low tech assessments. I don't know whether you remember coming across them, and the high tech meaning, you're being quite precise, and you were really interested in the minutiae of the testing and the detail and the results. Low tech meaning that you were, I suppose, more working on the person, and you weren't that interested
Mm.
in
Yeah.
being too precise about it. And at least originally we used to talk about that in relation to more tissue specific hypotheses. So thinking that there might have been a muscle pull, for instance, and being quite precise about it versus someone who had more widespread pain due to nociplastic processes or whatever we would call it now. Then we used to think about central sensitization and the role that plays in pain. Is that still holds, do you think? I mean, I'm so biased now, but I think that there must be some, strength in specific, precise testing for some problems, mustn't there?
Isn't that the clinical reasoning, the necessity of being very explicit about am I testing or are we exploring? So repetition, for example, may change over time, especially when you change things in terms of context. Telling people you're examining a nerve or just uh, a ligament, that might change the outcome. But if you are trying to figure out whether it's not like a reticular pattern or not, that's a different thing. You're probably going to shut down and not going to tell anything because you want a neutral. You're trying to prevent contextual factors to become in place too much that will influence the response itself. Even though with all the caveats going on, so I would, in my mind, I would say, am I testing? I'm trying to find an answer basically by deduct this hypothesis. And when I'm exploring, we go all the way, right? We can do anything that might be relevant or might be interesting. So I'm quite explicit to my patient to tell them, well, let's explore right now. I'm not testing. I don't even say I'm not testing, but we're exploring. So that gives a bit of, I'm pretty sure that gives you some more freedom to do something without any explanation or without conclusion.
Mm.
Or the conclusion is just we're observing this. It's painful in the first attempt, but it's less painful in the second, maybe. Or when you watch left, it feels better when you watch right. So when you think about this, it might be more tolerable when you think about something else.
Yeah.
Whilst you rotating your whatever.
Yeah. Yeah. Do you think that gives, a little bit of freedom here then to say, let's make sense of this together and yeah, more like a co-creation of an assessment in that respect?
Yeah. And it's harder because you don't know where to go, right? So there's no protocol.
Mm. Yeah.
And I do appreciate that it's harder when you're just starting as a newly grad. It's super hard when they tell, yeah, you can do whatever. Like, oh shit. Then I really don't know what to do. But and clinical reason, like a pattern or a protocolized clinical assessment probably is easier because it gives you a conclusion. You need to do this. And like this algorithm helps you to understand, but it's not necessarily, the focus is different because the test result is probably more important than the patient's response or feeling about it.
Yeah.
It's what I might be wrong there, but and I think when you're very experienced, you might be able to do this both at the same time and do the clinical reasoning while you're exploring.
Yeah.
But that's quite challenging, I reckon. Yeah.
Yeah, absolutely. To hold it all and be dynamic with it is really challenging. We're having this conversation and there's a few things that are jumping into my mind, but I remember, so I used to obviously work in the National Health Service in the UK, but I remember as a senior therapist just listening into a conversation of a more junior therapist and them saying, tell me when your pain comes on, or tell me where is your pain? And all the time the patient was trying to say something, which I never ever found out what it was, but I think it was something like, it's not pain. And they just wanted to sort of clarify that it was something other. And they never, ever got the chance to do it. And eventually they just submitted to this person saying, tell me, where's your pain? What's your pain like? When's your pain? And then they went, oh, my pain's just here. And and it's just popped into my mind. But you were saying about exploring and being curious. And I think that as being the exact opposite of that, of going, I will dictate to you what you will even feel.
Yeah, you could be. Sometimes due time restrictions or constraints, you might go like, if it like neck pain? Not asking about anything else, just because you don't feel there's time and space for other stuff that might be equally relevant. A bit like how you go, not the GP probably will be more interested in like a wider scope, but if you go to a neurologist, don't talk about your heart palpitations because they're probably not that interested. Well, you have to go to the other guy, the cardiologist next door. So, but from, let's say, our allied health professionals, we're not there just to look after their neurology or their cardiology or their whatever. It's always the big picture you get, isn't it?
Yeah, yeah, yeah. So then we mentioned about uh, physical assessment as a possible treatment as well. So, I mean, we talked about validation and reassurance. Is that what we're doing if that was the case? And I mean, how or what role might an assessment have in being therapeutic, would you say?
Yeah, that's great. I don't know for sure. Sometimes you feel like when we are testing, you don't want to let people fail, right? Fail the test. So, and some people don't necessarily have a reference. So I used to do this and now I can't. So it's pretty bad.
Yeah.
But in some cases, it's not that bad, right? It's they perceiving it as such, but if there's no reference, you can't say, yeah, compare to what. Um, and
How did I do, doc?
yeah, exactly. Well, you did pretty good. Oh, thank you. Oh, yeah, it's better than I thought. Nothing
Yeah.
changed. So I think it's giving people reference. I think that will be quite interesting. That's updating their intern model. You touched on before we started the recording about predictive processing and how we think we are and how we expect our body to behave or how we feel. I think a physical assessment or even any type of assessment or reflection on observing it could be potentially updating an internal model while you feel different afterwards. Could be some kind of an explanation of why people might feel totally different just after the assessments or the examinations.
Yeah.
Don't you?
Yeah. Yeah.
Yeah.
And there are times when you hear. I mean, I often think about the person that you only see once, and then you think, have they discharged me from their care? Occasionally, you get an opportunity to speak to them again, and you do have people where they say things like, I just felt so much better having come to see you, and it was just what I need, or it was it was just the right time, and I feel like I've got the resources to help myself and things like that, which is incredible to hear. But it would be nice for them to tell you that.
Well, it's also not, if you need to allow people to demonstrate their problem, because if you do all the tests and all negative, nothing, it doesn't mean there are no symptoms, right? So, from a clinical point of view, it's like clinical reasoning might turn into like all negative. Like, all right, so nothing we should worry about or you should worry about. But if that happens, I would be quite, strong opinionated on that. So just show me what's going on. I wasn't able to replicate your symptoms, but can you show me?
Yeah.
They might try to do something totally like, when I bend like this and I put my hand over, like, and I think about, no, when I turn like that, this is exactly where it is. All right, let's explore that.
Yeah.
So yeah, from that.
And we haven't mentioned, and there might be a lack of safety in coming back and all tests being, unremarkable or, I don't want to call it negative because it doesn't quite paint the right picture. But yeah, if you don't find anything when you're expecting to find something, actually that can be fuel to a bit more anxiety and worry and what have you regarding what's going on.
Yeah, and in some way, it's when, and I always felt session 2 is probably harder when you don't nail that problem. If people can't demonstrate their symptoms in the first session or maybe the second one, the third will be even harder because you don't have there's nothing such you were there with a therapist or a doctor. So what's going to happen? Is there going to change anything? If there's no change, or you haven't been able to demonstrate any type of change in any kind of manner, it's going to be very hard. And you're basically sort of seeking for even short-term relief. And I remember myself struggling there, finding this treatable component, if you like. And I generally go back to my old school manual therapy, hands-on style, and sort of forgetting a bit about the bigger picture. So it could be quite hard work if you have been able to change any type of prediction, right, in that predictive coding language. So yeah, could nail it or lose it in the first one.
Yeah, yeah. I mean, that's it's quite brutal, isn't it? But yeah, do it well or don't bother. I often think is
Yeah.
So maybe this is a good point to wrap up, because well, that's flown by. I'm going to do my best to sort of summarize what we've been going through. So we
Yeah, that's
obviously
great. Yeah.
you might need to help me out here, but we talked about using an assessment as an intervention in itself, and the role that plays. We're sort of biasing physical examination and saying that there is a merit there. And one of the things that I taken from our conversation is that we're not just doing it for us. We're doing it as this combined, as this team, and it's an opportunity to provide a bit of meaning and sense around what that person is experiencing, and guide us in that process as well. So something you've mentioned, and perhaps this is one for another episode, is being able to approach it with some sort of openness and curiosity. You talked about exploring and finding out, and I really like that, because you can be guided by that person, can't you? You can get them to help you out here. You don't have to do all the thinking. In fact, it would be much more much wiser for you to get that person involved here. There are opportunities within the assessment to just form a stronger bond as well. I think I would probably miss that off a little bit, but within that might be some reassurance and a bit of validation about what's going on, maybe a chance to de-threaten the experience as well, or notice how the experience is changeable by them in certain circumstances as well, and you can start to see where they can have some responsibility going forward in terms of their own treatment as well. We talked about the role of prediction here and internal models, and how we might be shifting the prediction that they currently have. Maybe another one for us, we talked about violations earlier as well, when we were talking about possible podcasts that we want to talk about. Within an assessment, we might be able to sort of violate some of those expectations and predictions in a positive way, in a good way, to help shift and change perhaps what might become quite a sticky internal model as well. Have I missed anything else out?
You were pretty, yeah, that was a good summary, I guess. If there's
Yeah.
anything people want to respond to, it would be lovely to hear from you guys. If there's any reflections on this matter, because I do think there are so many ways to go about, and this probably is our preferred language and way of thinking. We're biased as well.
We're so biased. We're so biased.
I just want to emphasize, we do this clinical reasoning, but it may sound like exploring, blah, 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 and then say, well, actually the clinical reasoning is our underpinning evidence-based model. But on top of that, there is this, let's say, opportunity, I would say. And if you're just starting to get your head around, so just make sure the clinical reasoning is right. Get your understanding and your knowledge in the right place and use it wisely, and then start exploring. And even if it's sort of like session 1, clinical reasoning, session 2, exploring, just make sure you feel comfortable with doing that.
Yeah. Lovely. It makes me think we need to talk about some clinical reasoning models and things like that as well in the future.
Yeah, well, we're good.
Thank you everyone then for listening in. If you got to the end here, thanks so much. Please share, tell people about it. Let us know how you use us as well. We do know that people listen to the podcast, and it is really lovely to know that there are people out there who benefit from our ramblings. So wishing you all the best and catch up soon.
See you later.